o'clock, so why don't we go ahead and start it? So as you can see, today's talk is going to be on dress, something we don't see too often, but something with life-threatening implications. So Michi Shinohara from Dermatology. I think we had a similar talk a few years ago, but something that needs to be reviewed every couple of years. So thank you for joining us, and go right ahead.
Thank you. It's an honor to be asked back for this. And yes, I'm going to talk today about dress. And I'm going to give you my dermatologist perspective and open to hearing yours as well. So I don't have any relevant disclosures for this talk. And my objectives are here. And I point out just at the bottom that there's a nice review that was written recently if you want to read a little bit more about dress. But just a little bit about drug reactions. I know I'm preaching to a very educated audience here, but drug reactions are really common. 2 to 3% of hospitalized patients are going to have some type of drug reaction. And about 2% of those drug reactions that occur in the skin are severe. And what do I mean by severe? I'll go over that in a minute, but tons and tons of skin manifestations of drug reactions. I'd say this is likely the most common reason for derm consult that we experience. Of course, morbilliform eruptions, urticaria, very common. But what we worry about are the more severe drug reactions like Stevens-Johnson, TEN, dress. But there's all these other things that we see maybe more often in clinic as well. But we worry about what people have termed SCAR, or severe cutaneous adverse reactions, ranging from Stevens-Johnson toxic epidermal necrolysis to acute generalized exanthematous pustulosis to dress. And we've got some warning clues about when those occur, but we'll go over a couple cases to highlight that. So the first one I want to highlight is a 20-year-old with fever and rash. And she came to the ER with these symptoms: fever, nausea, vomiting, rash, very minimal past medical history, only acne. And she had been started on doxycycline 1 month earlier for this acne. About 3 days after starting the 3 days before this presentation, so a little over 3 weeks into the doxycycline, she started developing this intensely pruritic rash. She saw her primary care doctor for that, who was the one who had prescribed the doxycycline. They stopped the doxy and gave her hydroxyzine and loratadine, but the rash continued to worsen and she started to get fever, as well as sore throat. So her primary doctor then started her on prednisone and antibiotics, but the patient's throat was too sore to be able to take the pill, so she came to the ER. And on exam, you can see that she's got erythema of the face trunk. And I want to point out this erythema of her ears and a little bit of edema. And I think you can also see that there's a little of edema of her face. She was febrile, tachycardic, had palpable lymphadenopathy, and on her labs, she had an elevated white count with some reactive appearing lymphocytes on the smear, eosinophilia, elevated liver function tests, and signs of synthetic dysfunction, and a slightly elevated BUN, normal creatinine. So here she is after admission on day 3. She got admitted, started on steroids, but you can see that that facial edema has been worsening and starting to get into some erosion around the nose and mouth. So our differential diagnosis in seeing a patient like this, and for her, you might consider viral infection, especially with the early presentation, that history of sore throat and rash. Of course, sepsis because she was tachycardic and febrile. I think this goes beyond morbilliform drug reaction in that there's so much facial involvement and the high fever. I think thinking about could somebody like this start to be evolving into Stevens-Johnson TEN is definitely a concern, especially with the erosion starting around the face and mouth. Although I'll say she did not have a lot of frank mucositis, which argues against that. And then, of course, our topic for today, drug reaction with eosinophilia and systemic symptoms, or DRESS. So DRESS, the other name for this is drug-induced hypersensitivity syndrome, which I like the name better, frankly, because I think it is more of a capturing term, but I don't like it because it's got the S and the H in the wrong order, and it doesn't make a nice word like dress, but dish. Drug-induced hypersensitivity syndrome. And DRESS/DISH was first described in patients receiving anticonvulsants in the 1930s. This term DRESS, though, didn't come about until the 1990s. And around the same time, a Japanese group described a very similar presentation, basically in parallel, that they termed DISH. The Japanese group, though, described this syndrome in conjunction with HHV6 viral reactivation. So this is a name that now encompasses all of these hypersensitivity syndromes: Dilantin, Bactrim, allopurinol, whatever hypersensitivity syndrome, now we can lump into DRESS or DISH. And it's actually one of the more common types of severe cutaneous drug reactions we see. The incidence is about 1 in 100,000 overall, which when you compare that to Stevens-Johnson TEN, which is for TEN more like 1 in a million, this is far more common. And for some drugs, it's much more common. For example, for anticonvulsants, and I'll talk about which drugs are more likely culprits in a moment. The clinical course of DRESS is really distinctive in that there is a very substantial delay of anywhere from 2 weeks to 2 months between the time of drug initiation and the development of symptoms. And oftentimes, symptoms are not rash initially. They're systemic symptoms like fever, lymphadenopathy. But those fever and lymphadenopathy are followed pretty quickly by rash in most patients. So that delay is very distinctive. And in parallel with that, often unbeknownst to patients, of course, visceral involvement may start to begin, like hepatitis, renal dysfunction. And a characteristic feature of DRESS is that these symptoms and laboratory findings can be very stuttering. So they can sort of go off and on for several months. So, another reiteration that there's often a substantial delay, weeks from drug exposure to rash. If you compare that to, what we typically see with a regular morbilliform run-of-the-mill drug reaction, as you know, that's usually more 7 to 10 days, maybe 14 days at the max from the time of exposure to time of symptoms and rash. When you compare that to 2 weeks to 2 months, this is quite a bit longer, and similar time course, by the way, to Stevens-Johnson for this. And then other key point here is stuttering and lengthy recovery with DRESS, which will show some more examples of how that plays out. So just to go over again, timing of different types of cutaneous drug reactions. On the one end, very delayed, weeks to months, Stevens-Johnson, TEN, DRESS. Kind of medium end, I said 7 to 10 days because I think that's most typical, but could be as short as 5 to 7, the regular run-of-the-mill morbilliform drug eruption. And then we also see very short drug reactions, meaning, hours sometimes from time of exposure, for example, for the fixed drug eruption, as well as very distinctively acute generalized exanthematous pustulosis, or AGEP, can have a very, very short time of exposure to time of onset of symptoms. So that helps us to think about what potential targets, as I'm sure it does you as well. Let's talk about some skin findings in DRESS, because there has been some literature around different patterns that can be seen clinically in DRESS. There's kind of 4 distinct patterns that have been described in the literature. The most common is what I'm showing here with this sort of morbilliform to urticarial look. A couple patients of mine, and then an exfoliative erythroderma, meaning, redness from head to toe with some peeling, can also occur a little less commonly. And then erythema multiforme, meaning with some annular or targetoid lesions, can also occur. Regardless, the findings in dress, skin findings in dress, are often very long lasting. That's also a distinction from morbilliform drug eruption, that patients can have rash that lasts for more than 2 weeks. It's actually one of the clinical features. And then it's often quite generalized, more than 50% of body surface area. In my experience, one of the more typical variants that I see, and this kind of goes along with the urticarial kind of papular look, is these tiny, tiny little bumps that are almost like BB-like, that are almost infiltrated feeling. That is a pretty distinctive kind of look, especially on the trunk, and I'll show you some more examples of that as we go on. There's also been described this very distinctive facial involvement in dress. Edema of the face, in particular periorbital. And here's a couple clinical examples of that, including a patient on the right with that, and in the middle with some real crusting around the mouth and the nose. And this facial swelling has been described as one of the more helpful signs for the diagnosis of dress, and certainly is something that we use to help distinguish from run-of-the-mill drug eruptions, because we really shouldn't, with the exception of patients who are profoundly immunosuppressed, like we would see on the hemonc floors, we don't typically see facial or head and neck involvement with morbilliform drug eruptions. So this type of facial edema happens in about half of patients with dress, and is considered by many to be a pretty distinctive and helpful sign when it's present. Patients can also have mucosal involvement with dress, but it's typically, as in these two patients, kind of light erosions, and it's often not something that patients come in complaining significantly about, as opposed to, they might have sore throat, but they're not saying my mouth is, totally raw, as opposed to Stevens-Johnson TEN, where patients often are completely denuded in their mouth. And so, just another example of what that might look like. So on the left, a little crusting. This looks like really extremely dry lips. On the right, clearly that mucosa is missing. In terms of what's common and what's not so common for the clinical presentation, almost everybody has some type of hematologic abnormality. Eosinophilia, I put here that it occurs in 95% because there's some series that suggest that, but of course it's in the name, but clinically I would say far less common, and it's likely because patients often are given steroids beforehand, which as we all know kind of ablates or drives down the eosinophils kind of quickly. But other hematologic findings, atypical lymphocytes like in our patient, and neutrophilia. High fever occurs in the majority of patients as well, and by high fever over 40 degrees sometimes. And then most people develop some type of organ involvement, including hepatitis, and there's some patterns of organ involvement that have been described. You would never say, it must be this drug because the lungs are involved, but there tends to be patterns of it, with hepatitis occurring more frequently in anticonvulsants, dapsone related dress, allopurinol driving more renal dysfunction, and minocycline driving more pulmonary findings. But one of the more serious findings that can occur is cardiac dysfunction, in particular a myocarditis. And a characteristic feature of that is that it can occur very late, meaning months after patients, have recovered. So that's something that patients need to be aware of, and people who follow patients with DRESS need to be aware of, that they could develop this late. And then lymphadenopathy can occur in about half of patients. It's not usually very dramatic, but it's often there. There are some diagnostic criteria that have been proposed for the diagnosis of DRESS or DISH. The European group has put together this one called Regiscar, and then the Japanese group has put together something called a J-SCAR. And this is an example of one of those. Regardless, all of them, and I'll just say clinically, I don't use this in the diagnosis of DRESS because all of the different diagnostic criteria include all of these things, such as rash, hematologic abnormalities, lymphadenopathy, organ involvement, weighting to some variable degree. And so often it's a combination of those things. A distinctive thing about the Japanese, I mentioned that they included HHV6 as one of their features of DISH when they described it, and that's included in their diagnostic criteria, HHV6 reactivation, whereas the other ones do not include that. So I think still some work to do about coming together with a uniform diagnostic criteria for DRESS. And I'll say that the Society of Dermatology Hospitalists has a work group looking at this. Shifting to talk about what are some of the medications that trigger DRESS. There are some common offenders, just as there are for other types of drug reactions. And it turns out 3/4 of the cases of DRESS are driven by either anticonvulsants, in particular the aromatic anticonvulsants, allopurinol, the antibiotic, sulfonamides, vancomycin, or minocycline. So these are kind of big ones. So when we see these on patients' drug lists, these are, rising to the top. But notably absent are some antibiotics such as beta-lactams or cephalosporins, which we know drive kind of regular drug reactions. And in the case of beta-lactams, some cases of Stevens-Johnson as well. I like this study. I will say that it's not specific to DRESS, but the Boston Collaborative Drug Surveillance Program is a older study that was revamped a little more recently, and they just looked at a huge group of patients and said, how many patients need to get this drug before there's a drug reaction in the skin? And so if you have a bigger number, that means more patients can get it, fewer drug reactions. And so it's just kind of nice to look at this list every once in a while and just remind ourselves, like, what are the things that are very unlikely to cause drug reactions in patients? Because patients, of course, when you go over their medication lists, it's often, a bajillion things. But the things that rise to the top for me as very unlikely causes are, of course, Tylenol, aspirin, prednisone. So, when we see those on drug lists, unlikely offenders. But as I mentioned with DRESS, beta-lactams, not impossible for sure, but they rise to the top of unlikely offenders. But we need a similar thing with DRESS here. You all are the experts in this about potential testing to confirm culprit drugs in DRESS, but we get asked about it sometimes. And my answer has always been that I don't think that there's a perfect confirmatory test. People have talked about, could you do lymphocyte transformation testing? It's generally negative while patients are hospitalized, but sounds like potentially you could do it after recovery, and maybe that would help patients determine whether they had DRESS versus Stevens-Johnson. Patch testing turns out to have a pretty high rate of false negatives. And that's because patients are often immunosuppressed, because of the DRESS, and we haven't gotten a treatment yet, but I'll tell you that we usually do pretty high dose steroids for most patients. And that, of course, is going to abrogate the patch testing results for many patients. There's some data about HLA predisposition to these types of hypersensitivity syndromes, and I just listed them here. And what we haven't gotten to yet, though, with a kind of real standardized approach, is when should we do this type of testing before exposure? And the reason is because the rates, even though there's a predisposition, the rates are still very variable about the risk. In the case of carbamazepine and Stevens-Johnson, that association did lead the FDA to relabel the drug. But in the case of DRESS, the odds ratio is still lower than for Stevens-Johnson TEN, even when these HLA, even when patients carry these HLA. So, it's not clear that it's cost effective or clinically meaningful on a population-based size to do this type of testing, but we need more data, basically. So stay tuned about that. We often get asked, can you do skin biopsies to prove or disprove DRESS? And as a dermatopathologist, in the other half of my job, I can comment that I always kind of have a deep internal sigh when that comes up, because the histologic findings of DRESS are kind of all over the place in the literature. And they're not that different than a regular run-of-the-mill drug reaction, with a few exceptions. And those are the cases that can be actually even more confusing when they can show really brisk findings, like an even pseudolymphoma. So all that being said, we do still do them, really because we want to rule out early Stevens-Johnson TEN, because that's, of course, going to impact patients' disposition, whether they stay, for example, at UW-Montlake, or whether they go to Harborview as a burn center, where they can get different wound care. So we do still do them, but we have a deep internal sigh about it. And we know that if we get non-specific findings, that may be perfectly reasonable for DRESS. DRESS has a not.
Michi, can I ask you a question?
Please, yeah.
Back on the last slide. So what are the critical differences on histopathology that tell you Stevens-Johnson TEN versus DRESS?
I will say with Stevens-Johnson, there can be overlap features. Generally, Stevens-Johnson TEN in the sort of totally epidermal necrosis phase will show interface dermatitis, kind of similar to a really brisk connective tissue disease. So there are some features that could help with that. You can see similar findings in just regular drug reaction and in DRESS, but it's generally more brisk in Stevens-Johnson TEN. Also, Stevens-Johnson TEN tends to be paradoxically less inflammatory than DRESS. And if we see full thickness epidermal necrosis, you can't see that. It's been reported in DRESS, but it does favor TEN more. And I think if we saw that on a biopsy anyway, we would likely, even if we were pretty sure it was DRESS, we would still think about referral to the burn center. So I think clinically that could be helpful in patient management if we saw that.
Thank you.
Yeah, of course. There is a mortality reported with DRESS, anywhere up to 10%. Newer studies, the Regiscar study, had it a little bit lower at around 2%, with kind of two things driving the mortality. First being myocarditis when it occurs, and the second is being complications from steroid treatment, including sepsis, pneumocystis, GI bleeding. So what is the treatment of DRESS? And I comment here on adults because children, there's slightly different literature, but of course the first thing is stop the drug, because presumably that's what's driving the DRESS, although there's some debate about that too. And one of our first interventions is to also recommend limiting new drugs, because you can have paradoxical flares or worsening and that stuttering pattern of DRESS, which can get very confusing when new medications are started and they're blamed for some of that, where it may just be the DRESS get very confusing. Systemic steroids are kind of the backbone of treatment for DRESS. What's been reported is, reasonable doses up to 1 mg per kg, but with a very slow, meaning weeks to sometimes months taper. And then I put IVIG here with an asterisk because there's some literature that in children, that this can be associated with the development of polyglandular autoimmune syndrome. So it's actually recommended not to use IVIG, though there is some literature on doing it in adults. That has not been our practice in derm at UW. We tend to really rely on systemic steroids as the backbone. And then I'll illustrate in a later case, part of it's not treatment, but part of the management of patients with DRESS is really monitoring for those late sequelae, such as autoimmune and then cardiac. So patients need to be followed after they recover from DRESS. And we see some in derm clinic, we see some, I'm sure you see some, we see some at the cancer center, actually. Because they come through hematology. A question that we often get asked is, does this patient need steroids? And it's debatable. It goes both ways. And when you think about the risk of complications from DRESS, steroid-related complications are one of the main causes of mortality when it does occur, and they're certainly a cause of morbidity regardless. But there is literature that steroids may improve survival and also may lower the likelihood of the development of late autoimmunity. So I think even though the literature is weak, here's a study that was done. Our practice still is to do steroids for most, really until we have stronger data to not support doing them. That's kind of a backwards way of doing it, but that's what we've chosen to do. We do run into some patients who then become dependent on steroids, and I don't mean from adrenal insufficiency. I mean that every time we try to taper them, they have flares of their DRESS. And sometimes it's flares of the rash, but sometimes it's actually, fevers and things like that recurring. And in that case, there is some literature on what to do to get patients off steroids. And personally, I have used mycophenolate and cyclosporin the most frequently, but literature has also described using plasmapheresis, intravenous immunoglobulin, with that caveat about case reports of that polyglandular autoimmune syndrome. Cyclophosphamide rituximab, I have not used that for this, but I have done, sometimes you need to do something because it's taken months and we can't get patients off steroids without, having significant flares. But a key pearl to know about is that when patients, and I'll talk about the relationship between viral reactivation and DRESS in a moment, but a key thing is when patients are then put on a second immunosuppression, like steroids and cyclosporin, in a kind of overlap period, very high risk of reactivating other viruses. I mentioned HHV6 can occur, but things like CMV and those symptoms can mimic some of the symptoms of DRESS, or maybe they cause DRESS. So it is recommended that if patients with DRESS are started on these types of immunosuppressants to manage their DRESS, that some type of monitoring occurs for CMV in particular, because that can cause late outcomes. So I'll just pause for a moment. Are there any other questions at this point?
Is there any role for any of the biologics, especially anti-eosinophilic ones here?
Oh, like omalizumab or
Or like Nucala, Dupixent?
Not that I'm aware of. We haven't tried Dupixent for this in particular. So maybe, but not that I'm aware of. We're trying Dupixent for everything, so maybe. Other questions?
Well, that sort of raises the question, why is there uniquely eosinophilia? What drives it in this disease?
Yeah, I don't know the answer to that, but I think that if we figured that out, we would probably be able to classify patients a little bit better, because like who really has stress and who has other things, because I think likely the driver of the eosinophilia is going to get back to the whole immunologic, milieu that occurs. But I don't know that anybody knows why. Open to
And why is this delayed?
Same concept. I don't think anybody knows. I would love to know the answer to that too, but I think it's, I'm not an immunologist, so very open to input here, but I think it goes back to something about the whole immune reaction that's triggered. I mean, it's similar when people talk about SGSTEN, why is the symptom so delayed when the exposure, likely triggers this whole, interferon TNF thing, sorry, not interferon, but TNF thing that happens. And, once it's turned on, it's like a on signal, and you can't stop it no matter what. I don't know, but we need to figure that out, because that would definitely help you. If you could like do some test for some, IL something in the blood and know that it's stress, that would be helpful to know, because you're buying patients, weeks to months of steroids. I think that'd be nice to figure that out, so we could really tailor patients' treatment. So you guys get to work on that.
Is there any classification? Again, I know you have this, the severity studies, but mild, moderate, severe, and when potentially using steroids could be of benefit in any of the severity with mild versus severe. Thank you.
Yeah. So I'll just say no. And it's very site dependent about when to use steroids and how long to use steroids for. Some sites every dress patient, regardless of the severity, gets steroids, period. We have not had taken on that practice here at UW, just because so many of the, we have a cancer center and we have so many patients who are developing dress in the setting of already profound immunosuppression, and starting them on steroids does not always feel like a very safe thing to do. So no, there are no like definite guidelines about it. But many have used particular literature about renal and kidney dysfunction to help drive decision-making around whether to start steroids, meaning if you have liver or renal dysfunction, that would be a indicator that definitely, yes, you should start it. But I think we have to figure out like, what is the impact on cardiac, those type of late outcomes before deciding like who definitely should get steroids, because I just don't think we know, which is a problem.
For something like the CMV reactivation, do you treat through that, or do you reduce their immunosuppression? Have you managed that scenario?
Yeah, yes and yes. So I have managed them obviously with the conjunction of ID, who has started, ganciclovir on them, but oftentimes we still need to treat with steroids through that, or whatever immunosuppression is driving their CMV. So yeah, we have treated it. And I'll just also add that we've had at least one patient who had like high level CMV activation during their kind of active dress too, not as a late sequelae. There's been debate too about should we be treating that with antivirals. But yeah, definitely the late one should be managed.
One more question. Do you have any studies with lymphocyte markers? Since the eosinophil counts and the biopsies don't seem to predict anything, are there any active lymphocyte subsets?
Probably. Yeah, I don't know the literature on that, but probably there. If there aren't, there should be. That I'll comment on.
sorry, one more follow-up question, is there any, many, again, data regarding, like you manage malignancy, that is there a role with like induction phase where you'd maybe go more, with the other second line agents first, and then, you may have better results?
Yeah, maybe there isn't good data now. I'll say like the French groups, there's one particular group in France that has advocated in the case of like Stevens-Johnson TEN using that approach. So starting with, cyclosporin for everybody, for example, thinking that that's going to kind of turn off the signal sooner, and maybe have, but we don't have enough data to, and that's definitely not been adopted sort of universally. So yeah, I just, until this is where the Society of Dermatology Hospitalists is trying to organize and do multi-institutional studies because, every group has their own sort of homegrown approach. And none of them are very data driven. And so we need to, like, number one, really well characterize how people are managing things, and look at outcomes. And then we need to try to develop some type of standardized approach to this, because there hasn't been a good one yet.
Thank you.
Yeah, of course. I feel like I haven't answered any of these very well. This is the problem with dermatology talks, is that often we're dealing with not the most ideal data, but we'll keep working on it. Okay, I'll show you another patient here, 40-year-old with a fever and rash again. So her history was that she developed upper respiratory symptoms, was given Bactrim. 2 weeks later, rash occurred. We encountered her here, where she was hospitalized with a pretty high white count, some mild hepatitis, sepsis syndromes, and she was started on prednisone at that time. Here's what she looked like, about a week into hospitalization there, very deep erythema, that sort of facial crusting, and facial edema as well. During the course of her hospitalization, despite steroids, her white count continued to rise. Her liver function test did normalize, so we felt that the steroids were still playing a role in improving the situation. Her at this point, the fevers had also responded to the steroids. We checked an HHV6 around here, and frankly, I can't explain to you why we would do it in some patients and not others. We don't have a uniform approach yet, but it was quite high at more than 1 million. And that leads me to a discussion about viral reactivation in DRESS, because as I mentioned, the Japanese group have included this in their criteria because they included it in their original description of DISH, but viral reactivation, including HHV6, can be detected in about 1/3 of patients. But EBV and CMV can also occur. And when they do occur, as I mentioned, with late CMV, they're associated with worse outcomes. So, up to 20% in the case of CMV, patients can have this. And so, people have debated about whether to do HHV6 or 7. If you think about outcome-wise, looking at EBV and CMV may actually be more impactful. There's some literature also that perhaps HHV6 reactivation is more linked to late autoimmune sequelae. So people have argued that we should be checking it for that reason. I just really don't think we have come to a uniform approach. And this is a kind of nice graphic I like about the sequence that can be seen in some patients between viral reactivation. So often HHV6 reactivation occurs or is at least detected earlier in DRESS. And some people have hypothesized that since so many patients with DRESS receive glucocorticoids, that then drives a late phase of viral reactivation. we don't know because so many patients get treated with DRESS, and very few patients have been sort of followed for like, what's the natural history? If you didn't treat with steroids, would patients then develop late, reactivation? And maybe that's the stuff that's driving their autoimmune sequelae. We don't know, but people do tend to have sort of a sequential reactivation of HHV6, EBV, CMV, kind of in sequence, especially with steroids. So more to know about that.
Question,
Yeah.
probably not known, but is this thought to actually be causative of DRESS or truly just an epiphenomenon?
I mean, not known, but like definitely debated, because people have argued that, these clinical findings that we see are almost identical to what you would see with, HHV6, 7, especially EBV, CMV, like especially EBV. A lot of the clinical findings, sore throat, that type of rash, are almost identical to what you would see. So people have really debated about that. And that's why there's some groups who say, no steroids, and other groups who say like, definitely steroids. Yeah, we're all over the place here with DRESS. But a related thing is, are steroids, driving that viral reactivation? Because we know they can, but in the case of DRESS, are they? And so people have looked at HHV6 level of reactivation, and have seen that when patients are given steroid in general, and this is not a big group of patients, but I think this was 30 patients, something like that, that when the patients who were given steroids, their HHV6 viral loads tended to be higher compared to those patients who did not receive steroids. And that treatment with steroids led to more prolonged viremia. And this is like really messy graph, but when patients basically giving steroids earlier, and I'm not even sure I can interpret this graph today. It's too early in the morning, but what I got from it is giving patients steroids earlier can actually, in the end, lower the end HHV6 viremia. So people have argued that if you're going to do it early, which is hard because you don't always even know that that's what the diagnosis is until certain clinical features come together. So I don't know about steroids. We do it, and hopefully we're collecting enough data to be able to justify what we're doing. We ask ourselves too, should we be checking viral titers? A really common question that comes up is it going to change anything? And probably not, probably no. Although some could argue that you could exclude Stevens-Johnson TEN, because if you do have clear HHV6, 7, which is definitely less common in Stevens-Johnson TEN, that could argue for DRESS. But otherwise, clinically, it's unlikely to change anything. But I also think we need the data about what the levels are and when they occur. And then there is that literature that HHV6 reactivation may be associated with later autoimmune phenomena. So maybe at some point that's going to help us determine who needs to be followed and for how long. So I think we should be doing this because I think it's going to help us collect that data for later. And then in the terms of checking viral reactivation for CMV, EBV, especially for CMV, I think that would be important to detect, although most patients are going to be symptomatic, but there also means also going to need treatment. So we go through phases with it, is what I'll admit to, that we don't do it regularly, and then a new paper comes out and we start doing it for everybody. So even dermatologists, we don't have a uniform practice around it.
Sorry, with that question about the viral titer checking.
Yeah.
So with that checking of it, is there benefit to checking it sequentially, like before or after steroids, if there is an activation or reactivation? viral titers before treatment and then after treatment, and when the timing of those titers might increase based off of initial disease presentation or before or after steroid activation. You have to check it a couple times to know if you're looking prospectively at the HV data and stuff like that. Is there benefit?
Yeah, I think there likely is going to be benefit and implications to timing of when you check viral titers. You know, in reality, we've used it mostly to help distinguish Stevens-Johnson TEN versus DRESS, you know, because it's helping clinically with triaging. Does the patient stay at this site or get transferred? But yeah, I think if you're going to be using them to help manage clinically, you probably do need to follow them. And I know some institutions do that, like follow titers on some particular timing, which, you know, always seems arbitrary because we don't know. So I think at some point we're just gonna have to decide we're just going to do this and, you know, follow it for group, which is what that Japanese group did with the HHV6. So yeah, I think if you're going to do it to try to help with clinical management beyond just diagnosis, I think you do need to follow sequentially. Yeah. All right, let me tell you about one last patient in the last few minutes. This was a patient who I encountered actually in one of my first few weeks of derm practice as an attending. He's a 32-year-old who came in with this rash. This was on his first visit, and he had about a week of the rash and reasonably high fevers. And his history was that a little over a month ago, he'd been started on Bactrim for acne. And I'll just say that is a dermatologist nightmare right there, Bactrim for acne. But his initial therapy had included oral antihistamines, topical steroids, and he had already been started on oral steroids, 60 milligrams for the past week or so without any improvement. His labs that we checked that day were notable for reasonably high hepatitis. His ALT was 420. And his CBC showed elevated weight count, but no eosinophilia, which was not surprising given his steroids. And on clinical exam, I think you can see on the right in particular on his forehead, he's got that sort of distinctive papular appearance, and then upper lip edema and edema of his ears. So, you know, very reasonable presentation for DRESS. We increased his steroids to 1 mg per kg. He was, you know, otherwise doing well reasonably, so he stayed an outpatient. But here's just another clinical look. But unfortunately, we could not taper his steroids. Even after 2 to 3 months, every time we would try to taper his steroids, his rash and hepatitis would flare. At that point, I actually went off to my dermatopathology fellowship. One of my colleagues took over his care, and that inability to taper his steroids persisted. So he was started on first cyclosporin and then mycophenolate to help manage his persistent DRESS. Here's what he looked like when I came back from my fellowship. And what happened in the interim is that 8 months after the initial presentation of DRESS, he started to develop blurred vision in his right eye, as well as abrupt onset of poliosis, which is just a streak of white hair. So kind of vitiligo-like, developed this sort of streak of white hair. Of course, the vision changes were alarming, and so he was seen by a retinal expert, was diagnosed with inflammatory scleritis, retinal detachment, which was thought to be consistent with Voigt-Koyanagi-Harada, which is an autoimmune condition that can occur in some Asian patients in particular. But that's not the cause for his hair loss. And we thought that the white forelock or streak of white hair was likely a little bit of vitiligo. But then he later went to develop this alopecia totalis variant of alopecia areata. And you can't see it in this image, but he also developed Graves' disease. So this eye condition, alopecia, vitiligo, and Graves' disease, 4 autoimmune conditions occurring, you know, kind of in rapid progression. So I mentioned that sort of stuttering clinical presentation that can occur in DRESS and the very long duration. But what I didn't mention is this late autoimmune phenomena that can occur that this patient demonstrated multiple ways. And this can occur generally months after presentation, and occurs in about 10% of patients clinically. But if you go looking for autoantibodies, which people have done in the case of thyroid antibodies, you can find them in up to 40%. Thyroiditis is the most common autoimmune phenomenon, either Graves or Hashimoto's, but alopecia areata is a close second. And then some patients can develop, this immune reconstitution inflammatory syndrome, IRIS, which I think he probably had, with multiple types of autoimmune conditions. Some people argue that treating with oral steroids early may reduce the incidence of autoimmunity later. So, some have argued that that's why every patient should receive steroids for DRESS. I think, we know that there's some bad outcomes with steroids. So I don't think that this is clear and, is preventing thyroiditis worth, potentially life-threatening infections or, a fractured hip. I don't know. Regardless, we do generally check thyroid function as we follow patients in addition to the cardiac monitoring. It's not clear, how long you should continue that for, but I've done it, generally 6 months to a year. Just to monitor for that thyroiditis because it's frequent enough in patients. And just to follow up on this patient, who was the second patient I mentioned, because she demonstrates another kind of unusual late sequelae of DRESS. She mentioned all these things that happened to her early on, but through her hospital stay, she continued to develop very high fevers and actually progressive pancytopenia and very high ferritin, over 100,000. And so she was diagnosed at this point with Hemophagocytic Syndrome, which has been known to occur in DRESS. But her steroids were increased and she actually was started on etoposide. So Hemophagocytic Syndrome can occur in the setting of DRESS, definitely been reported, but also has been reported to be associated with viral reactivation, or particularly EBV. It's a syndrome of, massive immune activation, of course, fever, cytopenias, high lactate dehydrogenase and ferritin are characteristic, but it's a multi-organ condition. And this is an example showing that hemophagocytosis in a bone marrow aspirate, just meaning one cell eating another cell. And so she got etoposide for hemophagocytosis, unfortunately developed very altered mental status, and imaging showed that she had multiple emboli, presumably septic. And she died 3 months after the onset of DRESS. It's a 40-year-old woman. It was actually quite traumatic to our derm team. So I think she really, for us, illustrated the downsides of high-dose steroids. And, I'm not sure what else we could have done differently. So to sum up today, DRESS, we know to be a multi-organ syndrome. Just to reiterate again, that delay of weeks to months between exposure and onset, characteristic facial involvement, edema, sometimes that crusting around the lips and mouth can be helpful for diagnosis. Jury's still out about viral reactivation, about whether it's chicken or egg, whether it's driving it. We currently do treat with high dose, slowly tapered steroids, but, expect and plan for that stuttering course, including the late autoimmune phenomenon. And here is your word of the day today. And I thank you very much for your attention and your questions. Good fodder for future
Thank you,
projects.
Michi. I was struck early on, I think you had 1 in 1,000 courses of anticonvulsants. This disease doesn't seem to be that common
Mhm.
to lead to that. That's sort of striking to me how frequent that
Mhm. Yeah, I
incidence
agree.
would be. You have any comment on that? Yeah.
I mean, that's like what we see at Harborview, on the Harborview derm service, with the rehab service there. It is very frequent. Yeah. Especially, that overlap, especially when people are not aware of that overlap with the aromatic anticonvulsants. I think sometimes people switch from one to the other and, continue to sort of drive dress. Yeah. My comment are it's surprising. And yet I think it's real.
Okay. Other comments? We have a couple of minutes left.
Yeah, Michi, just a question. Is the autoimmunity part of dress? Is it unmasking because of therapy? And then a related question, has anyone looked to see is pre-existing autoimmunity a risk factor for dress?
Yeah, I don't know that anybody's looked, thank you for that question. I don't know that anybody's looked to say, is pre-existing autoimmunity a risk factor for dress? But likely it is, if you think about the fact that certain HLA groups are predisposed to dress. So probably that plays a role, I would imagine. And the second part of that question, I lost track of it.
I guess it's hard to answer. Is it a delayed consequence of the disease? But often these patients are probably under immunosuppressive treatment by the time autoimmunity shows up.
Oh,
so I'm
yeah.
just wondering if it's hard to sort out, I guess.
It's hard to sort out, but it's likely driven by the disease, whether it's the viral reactivation or the sort of immune milieu itself. I don't know. I don't think it's driven by the immune suppression that I can comment, unless it's the immune suppression driving the viral reactivation.
Sure.
But there have been patients who were not treated with steroids at all who develop
Gotcha.
late autoimmune, and in fact, people have theorized
that probably those exceptions probably answer the question. Right?
Yeah, I think so. And also, just that when patients are treated with steroids, they actually have less late autoimmune phenomenon. So
great, thank you.
Yeah.
I had a question, trying to understand again the pathophysiology mechanism. Like you think about sulfa.
Go ahead. Sorry.
I had a question about sulfa and how it causes so distinct diseases between, you think about SJS versus DRESS. Mm-hmm. And, what is the drug hapten phenomenon, or what's the, again, other than the individual predisposition, whether it's HLA or other predisposition that may contribute to that, it's interesting that you have distinct disease from the same medication.
I totally agree. Yeah. And why does some patient just get like a sort of, they get like a pigmentary thing on their body and nothing else? I don't know. I'm going to blame the T cells because that's the other half of my job is cutaneous lymphoma, and it's always the T cells. But yeah, I people really, we don't know. There are people looking at, particular Stevens Johnson TEN immunology. So I think we've gotten furthest with that, but DRESS is so much more common, That's a total non-answer because I don't have one.
Can I ask one more question?
Please.
Do you think that this has anything to do with just the extended half-life of some of these drugs in the tissue? Like when you look at the carbamazepine and those drugs, they're strongly protein bound and they're going to last a long time.
Yeah. Maybe. That's why people have thought about plasmapheresis as a way to try to, clear the drug. Maybe. And that might get back to, was it Vinod's question about, what's driving it? And maybe it's those, complexes that are being deposited in certain compartments. I don't know. And there's, why do some patients have, hepatitis and not, renal? Is it deposited differently in different tissues? I just don't think we know. But maybe.
Thank you very much.
All right, thanks again. Just one comment for those who are still listening. We've had a couple of changes. I think we'll send out the revised schedule for the rest of the year. Just, I'm sure many of you who are who listen every week just tune in, not knowing what the presentation is going to be, but you might want to know in advance. So thank you all. See you next week.
Have a great
Thanks,
rest of the
Lynn.
day.
So long, Michi. Thank you very much.